Hello, and welcome to another live broadcast with MedStar Health. I'm Karen Zingle, and in honor of Colorectal Cancer Awareness Month, we're having an important conversation about risk factors, screening, and early detection. Today, we're also celebrating National Dress in Blue Day to raise awareness of colorectal cancer and support those affected by it. Did you know that colorectal cancer is one of the most preventable cancers? Knowing your risk is key. So keep watching to learn more about steps you can take to protect yourself and your loved ones. We're thrilled to be joined by Dr. Priyanka Kanth, a gastroenterologist and associate professor at MedStar Georgetown University Hospital. Dr. Kanth is the director of the gastrointestinal cancer prevention program, that's a mouthful, at MedStar Georgetown, and sees patients and families with high risk for gastrointestinal cancers. We also have Dr. Raena Olsen, a gastroenterologist at MedStar Health Gastroenterology at Silver Spring and MedStar Montgomery Medical Center. Together, they'll help us understand the science behind colorectal cancer and answer questions from you all, our viewers. So to find out more, keep watching, share this live broadcast with your friends, give us a like, let us know you're watching, and share your questions in the comments. We'll answer as many as we can. Before we get into some questions that I have, I'd like to give our experts a chance to share a little more about themselves and the work they do here at MedStar Health. I'll start with you, Dr. Kanth.
Awesome. Thank you, Karen, and thank you, MedStar, for giving us this opportunity. This is exciting. March is a big month for us. We want to talk. We want to talk all year about colon cancer prevention, but March is when we really want to talk about dress in blue. This is what we did today. We took a picture, and hopefully, and I've already posted it tweeted it. So this is all for awareness. I do GI cancer prevention. That's what I do. Basically, I'm a gastroenterologist, but I also do genetics. So I'm going to give you some insight of my practice and how genetics can be helpful in this area. I'm very excited to be here and very excited to be with everyone to answer any questions.
Yes, us too. Thank you so much. And Dr. Olsen.
Thank you for having me, and thank you for sponsoring this super important talk. The more we make people aware of how important colon cancer prevention is, the more lives that we can save. I've been a general gastroenterologist for the past 17 years. I see patients in Silver Spring as well as MedStar Montgomery in Olney, and I'm happy to see patients at any time to help.
Great. Well, thank you both so much. We really appreciate your time. And yes, this is a very important topic. So let's get into it. Let's start with a general overview of colorectal cancer. Dr. Kanth, I'm going to start with you. What is colorectal cancer? Start with the basics.
Yes, absolutely. So colorectal cancer, as the name sounds, is the cancer of colon and rectum. When we say colon cancer, we mean both colon and rectum. It's the same organ. It's the organ in the body everyone is familiar. Its main job is to absorb water, but that's where stool sits. And this is the organ which can have cancer like many other organs. I just want to let everyone know that there is a 5% risk of anyone to develop colorectal cancer in the US, and that's why we screen everyone at a certain age. And we'll go over that further. But basically, it's a very important organ which can have cancer, and we should look into how we can prevent it, and ages and the risk. We'll talk about that.
All right. Yes. Thank you. Good segue. Going to go to you, Dr. Olsen. Who is at risk for colorectal cancer?
There's a lot of different things that can increase your risk for colon cancer. Some of those things you can control, and some of them you just can't. For example, your age. The higher your age, the higher your chance of getting colon cancer. Most patients who get colon cancer are above the age of 50. With recent screening, that number has gone down. And on the flip side, we are now seeing colon cancer in patients who are less than the age of 50, which has changed our screening guidelines to 45. Another thing that can increase your risk is gender. Men are a slightly higher risk than women. That one is not so much, and it's important for both men and women to realize that colon cancer is the third most common cancer, both in men and women, and that's why screening is so important. Personal history of cancer or precancerous growth increase your risk. Having medical conditions such as Crohn's disease, ulcerative colitis, prior radiation to the abdomen because you've had cancer there before, those increase your risk. Being African American increases your risk, as does Alaskan and American Indian. Those are the highest risk factors. I'm sorry, the highest ethnicity and race for colon cancer. Some of the more interesting things that we can control is our lifestyle choices. Smoking, drinking alcohol, being sedentary, having an unhealthy weight, all of those increase our risk of colon cancer.
Thank you very much for sharing all of those risks. Yeah, lots of them. So let's talk about genetics specifically. I'm going to go back to Dr. Kanth. Can you explain how genetics plays a role in colorectal cancer risk?
Absolutely. And before I go there, I just want to let you know, and everyone knows this, and more people know, the better it is rising in young people. So traditionally, post 50, we now screen everyone for last 3 years, age 45, but we are seeing even younger people with colon cancer. So awareness is very much needed. We don't know what's causing the drive for most of the patients, but genetics does have a role. And I wanted to start with this because we are still lagging behind in finding these high-risk patients who we can still capture in terms of prevention. So not all colon cancer are genetics. That what I mean by that is if I do a genetic test on a patient who has colon cancer, I may not find a gene alteration in 70% or so, but we are going to find something in 20 to 30% of patients. And that's still a big number. And the younger you are with colon cancer, the higher the chances of finding a genetic cause. We know quite a bit about genetics of colon cancer, but maybe there's some more to know in future. But so far, we have around 20 to 30% of patients who will have a genetic marker. So in today's world, and this has been a guideline for many years now, if somebody gets colon cancer, we test their tumor for that certain genetic marker right away. This is a universal guideline. Everyone should have this tested. In fact, I would ask patients if your colon cancer was not tested, or the tumor was not tested, please ask if your tumor was tested for a genetic marker. And it's called Lynch syndrome, and we'll talk about that further. So around 20 to 30% is what your risk from the genetics is. We can talk more like how the risk changes in terms of genetics itself. So certain gene marker can make your lifetime risk of cancer very high to up to like double from the lifetime risk. So I said 5% risk, lifetime risk for anyone. That means you may not have any family history, you may not have the gene marker. But if you have a gene marker, your lifetime risk of getting colon cancer can be 10%, can be even 100%. So knowing that, and we'll dig deeper into it, like who should be tested, but there is surely a role of genetics. And I see a lot of patients, and I feel there are still patients who we could have tested for genetics. They may not have cancer, but their family history and or some other family members with cancer, we could have tested the person before they develop cancer. So having that awareness that not all colon cancer could have a genetic marker, but many of them, or at least 30% of them can have, especially if you're younger. And we should investigate that further with the genetic, history of cancer, et cetera.
All right, thank you. So yeah, in terms of genetics, are some people more at risk than others for colorectal cancer?
Absolutely. So if you have any family member, especially first degree relative, that means your parents, your siblings, hopefully like children, but anyone who had early diagnosis of colon cancer, and early or young means less than age 50 for us. So if you have a younger family member with colon cancer, that's a red flag. That's the time to talk to your physician. You may not have cancer, but that's where we want the prevention to come in. If you have multiple family members with cancer, it can be colon, it can be not colon cancer. So that's another interesting thing to be aware of. You may not have colon cancer in your family. Somebody in your family, maybe your first degree relative, or sometimes even second degree relative, may have something like uterine cancer, ovarian cancer, and you may not have any colon cancer in your family, but you could still be carrying a gene that increases your risk of colon cancer. So having that awareness that if you have any young family member with cancer, especially colon cancer, or if you have multiple family members with colon cancers or other cancers, talk to your physician. Talk to how do I get investigated this further.
All right, thank you. So yeah, how are genetic risks identified?
Absolutely. So one way, like I said, the usual way we are figuring out is somebody had cancer, unfortunately. So if somebody gets colon cancer, they are tested, and then they are sent for what we call germline testing, essentially looking at the DNA in the blood marker or saliva and see if you're carrying it, that you can pass it to the next generation. So that's how a number of cancer genetic marker patients who may be carrying them are identified. But another big way to identify is what I just mentioned. If you have a younger family member with colon cancer, you may not have cancer, but you could be carrying the gene mutation. And we can do the test. We can do a saliva test. We can do a blood test to find out if you could be carrying a gene mutation. If you don't have that younger member in your family available for genetic testing. So it can be done to find that out. Even if you have a distant relative or multiple relatives, you cannot get hold of their history or you cannot get hold of the genetics, you can still get tested, because what happens is if somebody has a gene marker, you have around 50%, sometimes less, but usually 50% risk of passing it to the next generation. So the affected person can pass it. You may not have still cancer in the next generation, but we can surely prevent. And the reason I say that, so for example, we start colonoscopy at age 45. If you have a gene marker, we start surveillance sometimes by age 20, sometimes even in the teenagers here. So knowing that is highly important, because now we can screen you sooner, we can find polyps, we can prevent cancer from that, and also prevent other organ cancer that may be associated.
All right, thank you. So I think I know the answer to this, but if colorectal cancer, if our viewers are thinking this runs in my family, what should they do? I'm hearing screening. What else?
To your primary care physician. First thing you should do is talk to your primary care physician or talk to your gastroenterologist, because we as a gastroenterologist may not see you when you're 30 years old and don't have any GI symptoms, but you may have a primary care. Even if you don't have a primary care, that's the time to talk to someone, a medical professional, to say, I have these, I have a young person with cancer, colon cancer, what do I do? And essentially the direction is, let's sit down, see how many family members have cancer. Let's refer you to genetic counseling, and let's see if you are eligible for genetic testing. Let's see if you're eligible for early screening. Let's send you to gastroenterology and see what your risk could be. So that's where awareness of knowing, okay, I have some disease, could I be at risk? And you may be completely healthy. You may not have any symptoms, but the whole point of doing this is let's prevent that. We don't want you to ever get cancer, and colon cancer is preventable. We can absolutely do that. And just talking to your primary care provider, GI, would be a great first step.
Great, thank you so much. And we're going to talk a little bit more about prevention shortly. And we also have a health risk assessment that is available through MedStar Health that we're going to share a link for in the comments. So you can certainly use that tool as well to identify your risk. But before we switch over to that, I did want to go back. You mentioned Lynch syndrome earlier. Can you talk, what is that?
So it's a genetic condition. It is a condition where you have these gene markers, and it's called mismatch repair genes. So essentially what it is when in your body DNA replicates, so it produces copy. It's like a photocopy machine. It produces copy. When it does that, it produces errors. So we have an error fixing mechanism in our body. And those are mismatch repair genes that comes and fixes the errors. Now, when these genes gets altered for whatever reason, they get mutated. That means they do not function the way they should. That is when your body is now prone to cancer. So Lynch syndrome is a condition where you have multiple of these genes, and usually it's one gene or the other that gets mutated or altered, and that increases risk of many cancer. So colon cancer is the highest risk in Lynch syndrome, but it can affect pretty much any organ of the body, except maybe not breast, but most organs in the body can be affected, and you could have higher risk of these cancer. Now, one thing I want to mention about Lynch, when we think about genetics, we think it's rare, it's uncommon. Lynch is actually very common. It's 1 in 300 person could be carrying a Lynch gene marker, and they don't know about it. And that is, we only get to know again from family history, or we have a high suspicion. And unfortunately, if somebody gets cancer, they get tested. So the data is 90% of patients who have Lynch do not know they're carrying a gene mutation, where we could have altered or can alter their prevention, not only of colon, but other organs as well. We can do early prevention. So Lynch syndrome is a condition all of us should be aware as much as we are aware about hypertension and diabetes. It's so common that it's about genetics, where we can do early prevention by knowing you're carrying a gene alteration. And Lynch being so common, I feel like everyone should be aware of.
Thank you so much. I was not aware of Lynch syndrome, so I absolutely learned something today. I'm sure our viewers did as well. So thank you for explaining that. Let's talk about prevention now. Dr. Olsen, I'm going to turn it to you. Can colorectal cancer be prevented?
You can't prevent cancer 100%, but there's many things that you can do to decrease your risk. And the best thing you can do to decrease your risk of colon cancer is to get regular screening. If you get screening for colon cancer, what will occur is we can find these changes in your colon soon, and fixing them when they're small is easy. So getting a screening test is the most important thing you can do. Now, if you are able to do some lifestyle changes, you may be able to decrease your risk and decrease colon cancer as well by maintaining a healthy weight, by doing regular physical activity, by having a diet that's low in processed meats, low in red meat, high in fiber, fruits and vegetables, eating from the earth. And also limiting your alcohol to 1 a day for a woman and 2 a day for a man, and avoiding tobacco altogether. But of everything that I just read, screening is the #1 thing you can do to try to prevent colon cancer.
Thank you so much. And I know, so during that screening process, the physician who's performing that test might see. Can you talk about what are they looking for? What can they see? I know I haven't experienced it before, but I've heard from others that have that. How many polyps did you have when that screening occurred? Can you talk about what are you looking for, and what is a polyp?
Sure. A polyp is a growth on the lining of the colon. It looks like a little mushroom or a little skittle. And it's just a bump that we see during a colonoscopy. We remove these little bumps and test them, and the pathologist will tell us if there's precancerous growths to those bumps or not. Not all of them have precancerous growths, and they're nothings, and many of them are precancerous. And once they are removed out of your body, they then cannot grow up and get bigger and bigger and occupy space in the lumen of the colon and through the walls and outside of the walls into the lung or the liver. So by removing a polyp, you significantly decrease your chance of getting colon cancer, because these little polyps grow up to become colon cancer.
All right, thank you so much. Are there different types of screening tests?
For better or worse, yeah, there's quite a few of them. It makes it a little bit confusing, because sometimes when there's too many choices, your head spins and you don't know which one to pick. So then when you go and talk to your doctor, often they'll tell you, there's different ways that you can screen for colon cancer. They typically will tell you about ones that are stool-based. Stool-based ones mean you collect your stool, you submit it, and that stool test will either look for hidden blood or it'll look for DNA that the polyp or the cancer will shed. Those are the stool-based tests. There's 3 of those. Then there is and one of them is Cologuard, which many of us, hear about. There's the FIT, which is commonly used that your doctor will prescribe. And then there's also the guaiac, which is the old-fashioned one where we put the stool on the card itself. And that's really gone out of favor because it has so many dietary restrictions and it's not as good. Then there's the direct visualization where we can actually see the lining of the colon. And that's done with either a colonoscopy or it's done with a sigmoidoscopy. And a sigmoidoscopy is a shorter colonoscopy because you only see about 1/3 of the colon. But that's gone out of favor too, because we know that 4 out of 10 cancers are found on the right side of the colon, especially in women. And a sigmoidoscopy doesn't actually go that far. So you'll miss 4 out of 10 cancers. So we've kind of gone away from that one. And then there's also the virtual colonoscopy or the CT colonography, where you get a CAT scan of the colon. And then the 3rd type of test is a blood test. But in reality, we don't really use these because these blood tests are terrible for detecting precancerous polyps. They're good, not great. They're good for detecting colon cancer. But remember, our goal here is not to find cancer. Our goal is to find precancerous polyps so we can remove them and we never have to have the C conversation with the patient. And remember, if any of these screening tests are abnormal, you must get a colonoscopy next.
And I just want to chip in there that if you have a genetic marker, none of the stool test applies to you. If you are high risk, it's only colonoscopy. So I just want people to be aware that stool tests are really for average risk screeners. That means you have no family history, you don't have a genetic marker.
Thank you. That's really important. Thank you.
Yes, thank you so much. So, which screening is the most recommended or preferred by physicians? You mentioned several of them. You mentioned it could be a little overwhelming. So, help our viewers. What would you recommend to them if they're thinking about screening at this moment?
Look, in reality, the 3 most common tests that are used are either colonoscopy, Cologuard, or FIT testing. The FIT testing is the stool testing as well. And by far, colonoscopy is our favorite. It's the gold standard because it's not only diagnostic. Yes, we can look for colon cancer and we can look for precancerous polyps, but there's something we can do about it. If we find those precancerous polyps, we can remove them right then and there. So colonoscopy is considered the gold standard and it's our favorite.
All right, thank you. What are the screening guidelines? What would patients need to do to prepare for a colonoscopy?
So the routine average screening is starting at the age of 45, which is new. In 2021, we've changed it to start your screening colonoscopy at 45. And this is incredibly important because a lot of people have it in their minds and they're thinking that you start at 50. And this has changed and it's important to know that. So for average risk patients, we start at the age of 45 and we do a colonoscopy once every 10 years or a FIT test once a year or a Cologuard test once every 3 years. Now, between the ages of 75 to 85, we really individualize it. We see how sturdy of a patient are you? How healthy are you? If you're a really healthy patient, I mean, you've met the people who are 75 to 85 and they are just really strong. We'll definitely do offer a colonoscopy to them if that's within their desire. On the flip side, you've met the people who are 75 to 85 and they look like they're 385, right? They're so frail and they're not a well patient. And in those patients, we don't offer it to them because we feel like the risk is going to be greater than the benefit. And the last thing we want to do is go in and hurt a patient when we're trying to help them. And then when you hit 86, that's when we stop.
Okay. Thank you so much for that. So what is the preparation for a colonoscopy?
So the preparation is definitely the hardest part of a colonoscopy.
Mm-hmm.
The test itself is a piece of cake. It's just the prep that's so hard.
Yeah.
And basically, you have to be on a liquid diet the day before your test, a clear liquid diet, and then you have to take a laxative to flush your intestines. We can't see the inside of the colon if there's stool in there, so we have to give patients pretty harsh laxatives to flush them out. Everybody hates it, and I often joke with them in the office. It's like you went to Mexico, you drank the water when you knew you shouldn't have, and then you get the diarrhea that comes with it. And it's pretty intense diarrhea. But
Mm-hmm.
look, the better you get cleaned out, the better we can see the lining of the colon. And the better we can see it, the better we can detect polyps. There's different kind of polyps. I described one as being like a skittle or a mushroom. Those are kind of easy because they kind of pop out and you can see it. But there's the more tricky kind, which are flat polyps. And those flat polyps are pretty tricky to find. And the cleaner your colon, the higher the likelihood that we'll actually find these polyps and remove them. And remember, the goal is to remove as many polyps as, or remove all the polyps really, so they don't turn into a cancer. Now, I do want to say the preparation for the colonoscopy is hard. People come
Mm-hmm.
in, and they're thirsty, they had diarrhea, it's a rough night.
Yeah.
But this test is only once every 10 years. You can do anything if it's only once every 10 years, and you can do hard things, right? The colonoscopy is your reward for the torture of the night before, and it's so easy. I mean, you go to sleep for the test, you don't feel anything, you don't even know we even touched you. Patients
Mm-hmm.
wake up and the first thing they say is, when are we going to start? And it's like, oh, we're already done. And everybody's so surprised. And it's, you get a chuckle out of it because it is a very positive experience. The test itself is a piece of cake.
Are you able to eat and drink after the test?
You can
There
definitely,
you
yeah,
go.
yeah, for sure.
That's great. And I have not had the pleasure of going through a colonoscopy. I'm not far away from it. But if a patient doesn't clean themselves out completely, like you were saying, you're unable to see as much as you would want to see. Are there times when sometimes you say you're gonna have to come back and do this procedure because we can't see, and because then you do all that prep work and then you can't get the colonoscopy. So you want to do it and do it right, right?
Yeah, it's really important to follow the instructions that your doctor gives you to cleanse for the colonoscopy. There's some people who have chronic constipation, and cleaning those patients out is, it's a little harder. So it's important that they mention that to their doctor, because maybe the doctor wants to give them a little bit of an extended prep, because it is essential to get a good cleanse. Because if you do come and your prep is not good and the cleanse is not sufficient, we do make you come back.
Mm-hmm. Yeah, makes sense. So you go through the prep work, you get the colonoscopy, you you mentioned earlier removing or taking some of the polyps. Can you talk about what happens after that? How is colorectal cancer diagnosed if there is a diagnosis to be had from a patient?
When we do the colonoscopy, colon cancer has a pretty obvious appearance. When you've done this long enough, you know when you're looking at cancer. And when you see something in there that looks off, you'll do biopsies. And you don't feel a biopsy being taken. Like, a patient will never know that a biopsy was taken unless we tell them, oh, hey, we took a biopsy from you. The biopsy is then sent to the laboratory. The pathologist will then read it and look for cancer cells. Now, every single thing that comes out of your body, every single polyp gets sent for testing. And the pathologist will give you information on what kind of polyp this is. If there is cancerous tissue, they'll be able to identify that, and they alert us immediately. And then we have that discussion with our patients.
Thank you so much. So can you, to close out the prevention and early detection discussion, can you talk about warning signs for colorectal cancer. So maybe you're not up with your screenings, but there could be an indication that maybe you have colorectal cancer. What would some of those indications be, those warning signs?
Early on, colon cancer is quiet. It won't give you any symptoms. And that part is really important for viewers to understand. People often will come in and say, do I really need a colonoscopy because I'm not having any symptoms? And my answer to them is, this is the perfect time to get a colonoscopy because early on in colon cancer, your body won't give you symptoms until the cancer has grown big enough to do so. Once it's a little bit more advanced, it'll start giving you symptoms such as rectal bleeding. That's a big one. Change in your bowel habits, meaning you're having constipation where you've never had that before, or you're having diarrhea and you've never had that before, and not just once or twice. I mean, this is a new pattern for you, and that's odd. The new pattern of bowel habits is what's off. Having stools that are pencil thin can be a warning sign. Abdominal pain, weight loss, those too can. If it has gone outside of the colon and you have shortness of breath, that could mean it's gone in your lung, or if you turn yellow, it means it could have gone into your liver. If you are bleeding from one of these polyps and you don't see the blood because it gets mixed in with the stool and you don't actually see the bleeding, it can give you anemia. And with anemia, you may get fatigued, you may get short of breath. But I also don't want to overscare people because there's plenty of symptoms plenty of benign issues that will cause the same symptoms that I just talked about. It's not always cancer, but it's important that you talk to your doctor so then they can try to figure out, are you somebody who should get your colonoscopy done sooner than later?
Mm-hmm. All right. Thank you so much. Appreciate all the wonderful information. So, Dr. Kanth, the goal is to, help people prevent colorectal cancer, obviously treat those that were diagnosed with colorectal cancer. Can you talk about reducing risk? We talked about risks earlier. So, who is more likely to perhaps get colorectal cancer? As our viewers are thinking about all of these things, what can they do to reduce their risk significantly?
Yes, and I just want to mention, we talked about symptoms, how it occurs late. And we are seeing younger people get cancer. A lot of us, a lot of these patients, we have no idea why it's increasing. It's still a conundrum, we don't know. But I just want to mention a young person who's in their 30s, 40s, get blood in stool, don't ignore it. Just because you're young. So it's just something to be aware of, because a lot of time you're young and have symptom and you just don't think much about it. But if it's persistent, please follow with your physician because you think you're young and you may not get cancer. So I just want to emphasize that part with the symptoms. How can we reduce risk? As I also mentioned, get your screening on time. That's the first thing. Colonoscopy or even colorectal, like anything you can do. You cannot get colonoscopy, get your stool test. Any test is better than no test. So please get your screening because that can surely prevent cancer. We have seen many patients with very large polyps, and we're like, oh my God, I'm so glad you were here today, that we could remove this big polyp. It happens every day, every week, I would say sometimes, that we are surprised that you have such a big polyp and no symptoms. So please get your screening on time. The second thing is, as going back to my genetics part, if you have a concerning family history, please get to your primary care doctor. Please talk to a gastroenterologist. Could you be at a risk? Could you start screening early in life? Could you be tested if you could be at risk? That would be the second thing. And the third thing, a very big thing, I think would be environmental factors. Like I said, 70%, 80% of the colon cancer do not have a genetic marker. We do not know what's driving it, but there's surely risk of, as Dr. Olsen mentioned, smoking, alcohol, maybe a very high fatty food. So doing all the right things, as we say, to be healthy, living a healthy life, exercise, eating right, avoiding too much processed food, those kind of things are all colon healthy. And this is all backed by a lot of research. There's a lot of research that has gone into very heavy red meat consumption versus vegetarian diet and all those. So there's a balance to it. Moderation is what I would recommend. Definitely do not do smoking. Like that is surely harmful. So these are the environmental risk people should be looking into. It's not only colon cancer, but many other cancers are influenced. So genetics you can't change, but you can surely do things that can avoid an insult on top of the genetic markers somebody may be carrying, or even for anyone who does not have a genetic condition. So prevention, knowing that colon cancer can be prevented with early screening and right screening, and don't wait on symptoms. I have had patients sometimes they ignored it or they went to a physician, but they were waiting and we're not sure when the screening or write-up. Anytime you have a question, ask us. We are very worried about younger people getting cancer or anyone getting cancer. So we really have a low threshold of investigating till we find an answer when somebody has symptoms. So that would be my recommendation, is to get your screening on time, get it before if you could be at a higher risk.
All right, thank you very much. So yeah, we talked a lot about screening, prevention, risks. If our viewers are out there thinking, yes, I need to take that step, I need to talk to my primary care doctor or my gastroenterologist, I need to get my colonoscopy, I need to order Cologuard. What if they have the screening and cancer is detected? Dr. Kanth, can you talk a little bit about what the rest of that journey looks like and how can MedStar help with the treatment process?
Yes, and MedStar is a great facility to be because we have a very good multidisciplinary approach to it. We have what comes next. So we do diagnosis. Somebody comes with symptoms or do not have symptoms, we do the colonoscopy. That's how we diagnose. But as soon as you're diagnosed, that's when we get everyone else involved. Do you need a cancer doctor? You need a surgeon, and they get to be seen by my colorectal. I actually just text my colorectal surgeon, and they're awesome. And they can see these patients very quickly. It's really a priority right away. And our oncologists are awesome. We have GI focus oncologists. So get them on board. And what happens is what they'll do is a staging, like how early or kind of late advanced cancer anyone could have. That we cannot really tell by a colonoscopy. So that needs further workup, like a CT imaging or so. And that is where oncologists and colorectal surgeon will start doing that workup. They sit together, talk about what stage the cancer is, and then there comes the treatment. And treatment varies and is changing. So treatment could be very early colorectal cancer, could be just surgery. If it's a little bit advanced, could be chemotherapy. Sometimes chemotherapy comes before surgery. If it's beyond colon, you may not be able to get surgery. So there are different, and I want to again go back to like how early prevention or getting colonoscopy or just knowing that you could have cancer. Stage 1 cancer, if you can find it, your chances of survival, 5-year survival is 90%. Stage 4, 13 to 15%. So that's the difference, finding cancer early. And oncologists and colorectal surgeon and us, we work together. Once you have had, say, surgery and chemo, and maybe you require further colonoscopy, a lot of our patients do get surgery and still have a lot of colon left. They will come back to us for surveillance again, and we would do essentially the lifelong surveillance. And we have different surveillance protocol how we do with somebody who had cancer, because they can get cancer again. We also look for genetic markers and the other aspect. So it's a really good combined team effort, and we help the patient throughout their journey. It's a very difficult journey, and we also have caregiving and support for that. Our oncology and other team members have other resources. It can be a long journey, but we have a lot of support. I want to let people know that in the world of treatment, there's a lot going on. There are things like immunotherapy now, which are very, very, very good in some of these genetic marker patients. So there's a lot going, and it's very exciting that we are able to almost near cure some of these cancer. It's not there yet, but we are really very hopeful that this will take us to that step where we can cure these cancer, almost cure these cancers. But I don't want anyone to get cancer. So I want prevention. We can remove these polyps and prevent. And I've had a colonoscopy. I've gone through prep. It's not that hard. It's tough, but anyone can do it. So please consider getting screening. If you can't get colonoscopy, please get your stool test on time.
Thank you so much. That was some great information. And yeah, really, really great to hear about all the support that our patients have if they are going through that journey. We had some questions from our viewers that we answered during the discussion. So thank you for those questions. Those were all of the questions that I had for today. So before we wrap up, Dr. Olsen, I'm going to start with you. I heard a few key takeaways, but before we close today's discussion, what is kind of a final message from you, or what do you want to make sure that our viewers take away from this conversation, or anything you want to reiterate or add?
Our mantra is colon cancer is preventable, it's treatable, and it's beatable. All you need to do is take the first step and let us help you on that journey.
Yep, I love that. That's a great mantra. Thank you so much. Dr. Kanth, I think you stressed screening as well, but any final words from you?
Screening. But I'm a genetics person, so I really want you to, go back, talk to your family members. Anyone had cancer you did not know. Anyone had young onset cancer. And that's the next step. Even if you're not 45, you're 30 years old, you're 20 years old, you want to know whether you could be at risk. So adding that layer, screening, absolutely, but adding that family history awareness is what I would recommend anyone to be, talking to your family members. So tonight, that's what you're going to talk about.
Love it. And yes, I had a friend who just turned 45 yesterday, and I will be texting her right after we close this broadcast to remind her about the need for her screening. So I think this was a really important discussion, and yeah, reminder to our viewers to not only have that conversation perhaps at the dinner table, but you can like, comment, share this broadcast with your friends and family to remind them of the importance of early detection. Well, thank you so much to Dr. Kanth and Dr. Olsen for joining us today. That wraps up our broadcast. Thank you to our viewers for tuning in, for asking your questions, and spending time with us as we share this important information. To learn more or schedule an appointment for that colonoscopy or for treatment, please visit our website. We'll put a link in the comments. Thank you so much for joining, and have a great day.
Thank you.
Everyone.